is this showing the slide here,
Yes.
Richard?
Yeah,
Yes?
it's showing Dr. Klausner.
Okay, so I have one slide, and basically it's going to go through some points for the trajectory of my career. I also shared a relatively recent Biosketch, and I think I gave you guys the Word version.
It's 19
So,
hours.
say again? We're good? Okay. So I also shared a Word version of the Biosketch for me. So you guys are welcome to, use that format. And it's a pretty typical Biosketch there for someone, who's been in the field for a while. And then I also share my CV, which is, a full academic CV. And you can see on the CV how different types of publications and activities are grouped and classified. So different universities tend to have different formats for their CVs. um, it is a painful process to maintain and update CVs in different formats. Um, Generally, I just try to keep a CV simple with publications and abstracts, and then just keep adding on to the publications and abstracts. But University of California wanted to see the publications by different kinds of publications, so peer reviewed, primary research reports, editorials, invited commentaries, reviews, and that was a little bit challenging. But anyway, in terms of my career path, I was graduated from Cornell in 1986 with a dual degree in chemistry and history of art. Um, while an undergraduate, I went to Peru in 1984 for 3 months, and that's really kind of where I started to think about, becoming more involved in international work. I mean, at that time in 1984, I was working as an assistant archaeologist, think I would do archaeology, but it started to open my eyes to some of the challenges globally, and some of the inequity between the background I had in growing up in northern New Jersey, New York City area versus parts of Peru. So then I went to medical college, and it was a 5-year program for me, as I spent an extra year between my third and fourth year going to Zaire. So Zaire, which is now the Democratic Republic of Congo, in the mid 1980s, was kind of one of the first places where heterosexual spread of HIV was being described, and particularly mother-to-child transmission of HIV. So I found a position with the CDC in Kinshasa, Zaire, and I was there for a year. And as a medical student, I was great because I wasn't really working for anybody. I was very independent, and anytime they needed someone to go into the bush or go somewhere to collect some specimens or do some, small task, I would be kind of the person who was available. So I got to travel a lot around the country, and I got to be involved in a lot of different projects in the laboratory with epidemiology. I got to teach a lot of local staff how to use, computers and epi-info and do data entry. And it was a phenomenal experience for me being in Zaire at the time as a medical student. And also that's where I first became kind of aware and exposed to this international public health world. There were people there from WHO, people there from CDC, people there from NIH, people there from Institute of Tropical Medicine in Antwerp and London School, and really kind of opened my eyes to, what the kind of mix of public health, could be with global agencies and also academic research in that setting, and those kinds of collaborations also locally, with the hospital and with the community. And we were at Mama Yemo Hospital, at the time in this was 1989. Obviously there's no therapy for HIV. So people would bring in family members into Mama Yemo and basically, bring them in there for palliative, end of life care. Um, it was, a pretty dramatic place to be working at the time. But some of the early research there was shown, that obviously mothers could spread HIV to fetus and newborns, and then what kind of intervention trials in terms of AZT could be done to prevent mother-to-child transmission. And my main project there was actually, or the one I published, was on the epidemiology of tuberculosis. So whether people with HIV were more or less likely to spread TB to their family members. And it actually turned out that they were less likely to spread TB because they were less likely, because their immune system was suppressed, less likely to develop lesions and cavities that were traditionally more associated with TB spread. So then after that experience, I went to do a residency at a large public hospital. So I wanted to be at a large public community hospital like Bellevue. And again, it was a very heavily impacted by the AIDS epidemic. So this is still prior to highly active antiretroviral therapy in the early 90s, and a lot of young men, men who have sex with men, people with substance use issues, and it was another kind of complicated, emotionally draining period to be working in medicine in the hospital and primary care. Um, but there was also a large tuberculosis ward there, and I got involved with some of the TB research there at Bellevue. And I was referring patients to a program that Rockefeller University was having with looking at whether they can treat patients with AIDS and TB with a drug called thalidomide. So many people may have heard of thalidomide. It's the notorious drug that caused birth defects in pregnancy, but it also had been discovered to have some anti-inflammatory effects and actually effects on tumor necrosis factor alpha and reduction in cytokine production. So similarly, somewhat to this fluvoxamine, thalidomide was being studied as an anti-inflammatory in AIDS and in TB. So they were doing these studies in New York City, and then also they had a research site in Chiang Mai, Thailand, in northern Thailand. So I basically volunteered during my residency to go and lead a study in northern Thailand to look at a placebo-controlled clinical trial of thalidomide versus placebo in the treatment of AIDS, TB associated wasting. And we actually saw very pronounced effects. People's tumor necrosis factor alpha measures came down, their weight went up on a course of a few weeks, and it looked very promising. And we actually had a mechanism of action, which was kind of cool. So then, as that was being further developed, for clinical use, antiretroviral therapy, combination therapy was becoming recognized as certainly a better way to treat AIDS and reverse wasting. And the thalidomide story kind of paused there. But ultimately, thalidomide got developed for use in other medical conditions, particularly multiple myeloma, and TNF alpha inhibition has been a big, kind of clinical area with monoclonal antibodies. But after that 3 years or yeah residency, I was emotionally exhausted, so I wanted to kind of pause from clinical medicine. So I decided it was time to get more training in public health. So that I went to Harvard School of Public Health. There I focused on at the time it was called population health and international health, but also took a lot of classes in epidemiology, infectious disease modeling, and for a physician at the time, it was just a 1 year degree. And I supported myself by moonlighting. at a hospital outside of Boston. So I could work in a hospital basically for 3 days a month, and that was enough to support my um, living and tuition expenses at the university for the year. So I wasn't really sure exactly, where I was going then. I had my, residency in internal medicine. I had this public health degree. I had some experience working overseas, internationally. What was I going to do? So I kind of wasn't sure. So I just applied to the US CDC Epidemic Intelligence Service, EIS, because I had met a lot of these people and graduates when I was working in Zaire. And I figured, it was a kind of a low chance of getting accepted, very competitive program, only about 50 or 55 spots per year. Currently, they still only have about 60 or 70 spots. It's still a very small program. Um, and I was accepted, and I went there to start in July 1995, actually. And then before you start there, they have what's called like a match. So you go for April, for a week in April. They have a lot of lectures and presentations of all the current officers. And then it's I don't know if you ever have heard about like fraternity or sorority matching. So you go to different programs and you meet them and you learn about what they do, and then they try to recruit you. So the special pathogens people who are doing, like Ebola, they're trying to recruit you. The foodborne disease people who are doing Salmonella, Shigella, they try to recruit you. The AIDS programs, they're trying to recruit you, because for these programs, there's many more spots than there are officers, and the spot for the program is fully funded by the training department. So they're very, you're essentially free labor for them, and you're have good training. So it's kind of a nice position to be in, to be heavily recruited. But through that process, I had no idea what I wanted to do. And actually, I wasn't really keen on staying in Atlanta or being in a basement somewhere at CDC. And I was a little bit, I don't know, kind of disappointed, I guess, in terms of what the opportunities were. So on the last possible day of this recruitment week on Saturday, I met somebody from San Francisco. And the CDC not only, has positions in Atlanta, but it has about 20 positions or so outside of Atlanta in major cities and major states. So in New York City, in Chicago, in Los Angeles, and in San Francisco. So I never thought about, even working in a local city health department. And I spoke with the people in San Francisco, and they were like, sure, you can come to San Francisco. You could work, with us on HIV, if you have your interest and experience. You could also work on STDs. You could work on other communicable diseases. You can work on other issues we deal with as a local health department. And I said, that sounds very interesting to me, because it was broad. It wasn't so specific. And, it would be an opportunity to live in San Francisco. And I never had been to California or San Francisco prior to that. So I accepted that position, and in 1995, moved with my girlfriend to San Francisco. And very early on, I was involved with the HIV/AIDS response in San Francisco, with STDs, syphilis, gonorrhea, chlamydia. And it was fascinating for me to work at the local level with the health department that actually had a decent amount of resources. So San Francisco has a population of about 800,000, and has one of the, bigger, more robust budgets for public health per capita in the country. And that's why, a lot of the science of public health and publications and leadership and innovation comes from San Francisco, because they actually have the resources to be innovative, and more importantly, to evaluate and share evaluation outcomes of their innovation. So I learned in public health, as in medicine, unless you can evaluate what you're doing rigorously and then share that, you're not going to have a lot of impact. So I did that for 2 years, but then I started to get a little bit frustrated with the bureaucracy. So working for the federal government, as you might imagine, every time I wanted to leave an hour early or take a day off, I had to sign a permission slip. It had to be like faxed back to Atlanta. I had to have a supervisor sign off. There are a lot of different rules, and arguably I'm not necessarily the best when it comes to a lot of rules. So I said, okay, I'll do that for 2 years. And then I want to get it back into academic medicine, with the freedom of academic medicine. So I applied for an infectious disease fellowship at University of Washington because that's where one of the leading researchers in STD was working, a guy named King Holmes, who essentially wrote the textbook on STDs and chlamydia, gonorrhea, and syphilis. So I went up there. I was going to do a full 3 year fellowship, 1.5 years of clinical training, a year and a half or two of research. And halfway through the first year of my fellowship, I got a phone call from San Francisco saying that my supervisor in San Francisco had left and they wanted to recruit me to take over her position as director of STD and HIV for San Francisco. And I was like, wow. Uh, that's a big job. I finally got out of, the bureaucracy, and I want to do research and I want to stay at University of Washington in academics. So they said, okay, no problem. Thank you very much. And then they called me back like 3 months later and said, listen, you really are the best candidate. We would love to have you come down to San Francisco. What would it take? So when you're negotiating, which is, honestly, probably pretty rare, and someone says, what would it take? You're in a great position for negotiation. So I think Richard sent out that link with that science paper on academic negotiation. Did you send that out, Richard?
I think it was included in the reply, Dr. Klausner. Let me double check again.
Yeah,
Yeah. So
I got it. I got it.
all right, great. Yeah. So that's actually a great article. And that was one of my mentees who wrote that article. So a lot of his insights come from me in that article. But basically, when you're negotiating for any kind of position, you actually have a lot of opportunity there. And you can't really be too, you can't, forget about the details. So when I was negotiating for this position in San Francisco, it was a health department position. It was a deputy health officer position. It really did not have any academic relationship or affiliation. So I said, well, I do want an academic affiliation. I want an academic appointment at UCSF. I want to be able to teach. I want to be able to, attend and see patients in the hospital. And they said, oh, okay, yeah, we can kind of make that happen for you. And I said, I want to do, research, and I want to do international work. And they said, well, San Francisco Department of Public Health is really not about international research or global health, but, we have different people who do different things. So yes, we'll give you permission to do that. And then I said, okay, well, what else can I ask for? I said, also, well, I want a parking space. And they're like, no, parking space. Parking is based on seniority and you'll be a new employee. So we can't give you a parking space. So actually, I said, no deal. I said, no, thank you. And then someone from like the parking department called me up the next day and said, oh, we have a parking space for you, Dr. Klausner. It's in the basement of City Hall, which is about a block and a half from your office. Is that okay? So I said, absolutely, that's okay. And at this point, I had gotten everything I asked for. So you're somewhat obligated to take the job with the negotiation. And then we just had to work on the timing. And this was April, and I still wasn't done with my infectious disease fellowship, which was going to, at least the first year to be board eligible, was going to end in June. So I had to negotiate and then again for a start date in July. But, they really wanted someone to start there as soon as possible. So we ended up with a June start date. So I left my fellowship early. I was able to be board eligible, and I was able to use my research from my time with CDC. And then I started in San Francisco in June 1998. So I was a health official there basically for 11 or 12 years. Really enjoyed it. It was a fantastic position to be able to combine public health and academic life. Being a full-time uh, city employee, I didn't have to stress about grants and research and soft funding, right? I had a full-time salaried position with the health department, but could put on my UCSF hat and go to rounds and see patients and do research at the same time. So it really was a win-win for a nice period of time. But then after about 11, 12 years, I started to get a little bit, looking for something else, something different. Always had that kind of public health and global health piece kind of tugging at me. And PEPFAR at this time, the PEPFAR program was really kind of building its strides. People were starting to hear a lot more about it. PEPFAR was started in 2003 in a few countries, but really started to pick up steam in the next PEPFAR round in about 2008. And so I was encouraged by lots of colleagues to reapply to CDC as a medical officer and then work on one of the PEPFAR programs. So at that point, you didn't really get to pick and choose where you wanted to go. You basically become a CDC officer, medical officer, and then based on the need, you'd be assigned to a different country. So, I was hoping to get to what I considered a smaller, more mellow country, Swaziland, Namibia, um, and I was assigned to South Africa. And I was a little concerned as South Africa, for me, had a reputation of being a very busy, complex environment, and how effective could I be in that situation? And in the time it took, which was like 6 months to do the transition and go through the hiring process and the background checks and all the paperwork, the chief of the AIDS and tuberculosis program in South Africa had been promoted, and he had left. And now there was an empty position sitting in the CDC South Africa program overseeing all of AIDS and TB for CDC. So by the time I got there, I was assigned to this position to be branch chief. And that was a phenomenal opportunity and a tremendous budget and relationship with the National Department of Health in South Africa. And really were able to get a lot done. This, people who know history may know that at this point, and Becky, who had been the president of South Africa, had left, and Zuma came in. There was a big shift in the understanding of HIV/AIDS and the response, and there was a big push to scale up treatment. So I was there right at that time with a lot of resources from the U.S. government to help them scale up treatment. So I did that for about 2.5 years, and then my wife and I and children moved there. We lived in Pretoria. We were living the expat life, and everything was going very well. Usually those positions are 5 years or 6 years. And my oldest son was about to go to high school, and we had to decide, based on the family, did we want, my oldest son to go to high school in Johannesburg or go to high school back in California. Also, honestly, there was ongoing issues about security and safety. And in Pretoria or Johannesburg, CDC staff, had unfortunately suffered home invasions, kidnappings, violence, a lot of robbery, and just was not the safest place for a family. So we had to decide as a family, should the family go back to California? I had 3 children at the time, or and I should stay. And ultimately, I decided to move back with the family. They went back about 6 months earlier. And so then I had quit CDC for a second time, and I had to figure out what I wanted to do next. So we wanted to stay in California. So I applied then to UCSF, Stanford, and UCLA for a professor level appointment in infectious diseases and global health. It ended up UCLA gave me a great opportunity and startup package, and they were building up their global health program. So I've been there for 9+ years, and actually am leaving UCLA in 10 days. January 31st is my last day at UCLA. And then I'm going to be part-time at USC. And USC is going to give me a lot more freedom to operate and do more creative and collaborative things. So part of the theme is, if you've been listening carefully, is I like to do kind of interesting things in environments, but at some point the environment becomes a little bit claustrophobic for me. So I need to find some new space to be able to maintain collaborations and creativity. So I do a lot of startup things now with biotech. I do a lot of kind of consulting commercially, do a lot of things online with different apps and programs. And UCLA did not kind of support some of those things. So USC being part-time faculty gives me a lot of freedom to still, be a academic faculty person and manage a lot of my grants outside the United States. So I have NIH now 3 R01s in Peru, South Africa, R21s in Vietnam and in Botswana, and then some other projects here in the United States. So USC serves as the academic home for those. But because I'm part time, I can still do a lot of outside university work. And for me right now, that's an important area to be able to continue to have an impact. And particularly with the COVID pandemic, I'm very involved with a big testing and vaccination company that has been doing a lot of work around the United States. All right, I'm going to pause there on that kind of narrative and see if there are any questions. Thank you very much. Let me see if I shut this down.
So, Dr. Klausner, I just have a quick question on what do you think were the what were the key characteristics you exhibited that CDC had to track you down, and was it CDC or the City Health Department had to track you down to help to allow you to negotiate your own package?
Yeah, that's a good question. So, I think, for me personally, it was a lot about innovation and creativity that, I've been an out of the box thinker. So early on, with the AIDS epidemic, I saw an opportunity that people, could do their own testing and self-testing. And, a big barrier was going to the doctor or going to the health department for testing. Another issue was there was a lot of paternalism in HIV, and like you would get your HIV test and then you'd schedule a week later to come back for a counseling session to go through your HIV test results, and it just was very difficult. And I wanted to eliminate those barriers and enable people to get HIV tested specifically anywhere, to have them get, rapid tests or at least rapid results, and just to kind of be more practical. Also, I think the evaluation component. So I've always, been very focused on evaluations and publications and reports and sharing kind of outcomes. So, there's kind of little I do where I don't think, okay, well, how are we going to evaluate this and share the report? So a nice example coming up Friday is fluvoxamine. So I just independently am convening on Friday this expert group on fluvoxamine with people from CDC and NIH and IDSA. 20 people are going to review the data, and then we'll come up with a study report from that. So I think, people see kind of a lot of just like self motivation and independence and the ability to get things done, and don't necessarily require a lot of direction or supervision, which is a little bit of a double-edged sword because people work really well independently, sometimes can go off track, and sometimes can do things that may not be what the institution wants to be done. So it's sometimes a little bit tricky. You want to be creative and independent, but you want to stay within the bounds of the institution, and institutions generally are conservative, right? You know, they, they like new things, but they don't want to be too new. So it's sometimes a little bit of a tension there, which is definitely something I've, you know, experienced in my career. So a question about academic credentials and how that, you know, contributes. So yeah, I think that's definitely very important. So, you know, if you look at my CV, you know, it's a 100 pages CV. If you look at the Biosketch, you know, I mean, you definitely need to, you know, at least currently in the, you know, very competitive climate about grants and research and academic faculty appointments, you need to convince people that, you know, you're productive, and, you know, productivity is still measured on grants and publications. And one of my successes in publications from the beginning has always been a lot of collaboration and bringing on a lot of students. And so, you know, very early on in my career, I was a senior author, where I would identify students and trainees and people who want to write, you know, publications. So, you know, right now I publish about 40, you know, manuscripts a year. I mean, that's almost one a week. And I can only do that because I have a whole large group of different students and residents and trainees. So if I have, you know, 20 of them and they're each writing 2 papers a year, which from their perspective is not that much, it's doable, you know, then for me, I can get 40 out a year. So it's kind of, I've always been, for, you know, whatever reason, I had a large group and building this out in terms of, you know, productivity.
So what I've noticed in the past, the last 3 months, when we've been doing these career webinars, is there's a lot of moving jobs. So you haven't kept the same job for the last 20 years. You've moved, you've stayed in one place for 3 years, 20. And traditionally, there's the thinking that, oh, okay, so you stay in this job and there's job security and pension, etc. So how do you balance that?
Yeah, no, that's a good question. So you'll often see a lot of people in global health, you know, it's just kind of bouncing around, right? They'll go to WHO, they'll go to, you know, the
Yeah.
Gates Foundation, they'll go to different places. So, you know, I think that's just part of the ambition, right? And people keep looking for different opportunities for more and more responsibility. And, you know, you have to have a family which is supportive of that if they're going to be moving. You also have to have, you know, a little bit of personality that's, you know, open to something new. I mean, every time you transition, it's, you know, it can be fearful. I mean, you just don't know what to expect. You don't know how successful you're going to be. And you got to be someone who's, you know, okay pushing yourself out of your comfort zone. So, like, you know, I just resigned from UCLA after 10 years in a very comfortable professor position. And, you know, for me, it just, it's invigorating to reinvent myself and to get out of a rut. So if I feel like I'm in a rut and I'm just like calling it in and I'm not pressuring myself, you know, I like say, you know, what else could I be doing, you know, differently? And, but it's, you know, that's my personality. So, you know, different people will be like, just very happy having the same job and maybe, you know, doing different things within that job or working with different people or changing their focus a bit. Um, but you do have to be careful about changing focus too much. So, I mean, I've had a continued threat of STDs. So that's been kind of the rock solid core of all my work. So at this point in my career, I, you know, have a reputation of STD expert, so syphilis, gonorrhea in particular. So when people need, you know, experts in that area, they, you know, come to me. You know, I'm not a COVID expert per se, but I've been, you know, doing more with COVID over the past year just because that's where the pandemic is. And as an infectious disease epidemiologist, I can apply some of those principles. So I think it is good to have some flexibility and, you know, look for opportunities and say yes. You know, WHO has a lot of consultancies that they make available for 6-month consultancies, one-year consultancies. It's hard to get those consultancies until you've been a consultant. But sometimes you just have to say yes and take a 3-month consultancy in the Philippines, to just like achieve that and get that done. And then when another consultancy comes up, so every week I get, request emails to like pass out and find consultants for WHO. Similarly, UNAIDS is always looking for short-term consultancy. So I think those things, particularly for people, living and working outside the United States, are good opportunities to kind of build up their network and build up their experience.
Thank you.
All right, well, I'm going to wrap up. I know I went over, but thank you everybody for your time and participation, and good luck, and we'll talk next month.
Thanks, Dr. Klausner.
All right.